Hi, my name's Matthew Links. I'm a medical oncologist from Alice Springs Hospital, and welcome to this video in our series 5 minutes of remote cancer care on immunotherapy with checkpoint inhibitors. It's aimed at health workers in remote communities caring for patients on one of these drugs. And I'd like to start by acknowledging the Aranda people on whose land I live and work, elders past, present and emerging from this community and all of the remote communities who get care with us. The goal is to focus on practical issues, both in the acute setting with symptomatic presentations and the setting of ongoing care. There are multiple types of immunotherapy, but this talk is confined to drugs that act as checkpoint inhibitors to stimulate an immune response against the cancer. A key task is to communicate in a simple way what immunotherapy is. We like the metaphor of cancer being like a weed, for example, buffel grass, that takes over country. Your immune system can normally take care of your body like rangers take care of country, but if it gets overwhelmed, the cancer takes over. Immunotherapy boosts your immune system, like boosting the number of rangers, so your country or body does not get overwhelmed. Now, I would highlight that people use the word immunotherapy in different ways. Checkpoint inhibitors activate T-cell responses against the cancer and include drugs such as pembrolizumab, nivolumab, atezolizumab that target the PD-L1 pathway, ipilimumab that targets CTLA-4, and relatlimab, which is a LAG-3 inhibitor. One of the challenges with immunotherapy is that for many patients, the burden of toxicity is less than chemotherapy, but on the other hand, toxicity can be unpredictable, can affect any organ in the body, and can be severe or life-threatening. Common issues are colitis, pneumonitis, hepatitis, and endocrinopathies such as thyroid or adrenal insufficiency. Hypoadrenalism is a particular problem, and any hypertensive patient should be considered as potentially adrenally insufficient. The biggest challenge is to suspect it and when you're thinking about immune adverse events. This requires, first of all, realising the patient's on a checkpoint inhibitor, which can be difficult. It's our job to communicate clearly exactly what treatment people are on. There's a lot to be said for Googling unfamiliar drugs. The second step is asking the question of any presentation, could this be an immune adverse event? Particular problems are subtle presentations such as adrenal insufficiency or hypothyroidism, as well as presentations where it's easy to blame something else and miss the reversible cause. Increasing cough in a patient with lung cancer, for example, and COPD is a typical issue. The final step is to access help and respond. Particular reminder for patients who are hypotensive to consider hypoadrenalism. Now, there are specific scales for each toxicity, so once you think about this as a toxicity, you can match the response which is required to the grade of the toxicity. Now, you can't remember all of them, but there are some principles that in grade 1 or mild toxicity, we reinforce education, think about alternate causes and plan for if it escalates. Grade 2, which is moderate or interfering with function, there's a need to escalate and consider urgent steroids, withholding treatment, consider transfer of care to an environment where the patient can get expert specialised care if they deteriorate. Grade 3 will need admission, workup, high-dose steroids, and they probably won't be able to restart the immunotherapy. And grade 4 or refractory immune adverse events may require additional immunosuppression, which can get complicated. Here's an example with the guidelines that we'd use to follow, say, for a gastrointestinal toxicity. The 4 liquid stools a day over baseline counts as moderate and requires intervention. Same principle of thinking of alternate causes such as infection, but not ignoring the toxicity because infection is considered. Management or refractory or severe case require steroid-sparing agents and gets complex. Now, as with all cancers, a major role in primary care is providing ongoing support, identifying any unmet physical, psychosocial, cultural needs. This is an invaluable feedback mechanism, so identifying these needs, mobilising the supports available in the community and communicating back to the oncology unit is very helpful. There's a lot of additional information available, and particularly useful is the EverQ website, which has a general handout on immunotherapy, specific information on individual protocols, and a section on management of immune toxicities. If in doubt, reach out to your cancer clinic. So thank you. Good luck with the care of your patients. And thank you to all those who reviewed this site. Please email any feedback or leave it on the YouTube channel. Looking after these patients is complex. It requires a partnership between the cancer clinic and primary care, and your input is appreciated. Good luck.